Hello, and welcome to our virtual symposium entitled Antibody Therapy in Acute Leukemia, Understanding Clinical Considerations for Use in Conjunction with Hematopoietic Stem Cell Transplantation. I'm Professor David Marks from the University Hospitals Bristol NHS Foundation Trust in the UK, and today I'm joined by two colleagues, Dr. Farhad Ravandi from the MD Anderson Cancer Center in the US and Professor Matthias Stellis from the University of Munster in Germany. So this is today's agenda. It's a masterclass and practicum session. First, there'll be an update on novel antibodies in AML and implications for transplant-eligible patients. Secondly, I'll give a talk on evidence on antibody-based approaches to managing ALL in the HSCT context. And finally, Professor Stellis will present a series of case discussions exploring the practical use of antibodies in the HSCT setting. So if we can move to the first talk, I'd like to introduce my colleague, Dr. Farhad Ravandi from the MD Anderson.
Thank you very much, David. And I also like to thank the organizers for giving me this opportunity to present some data on the use of antibody-based strategies in acute myeloid leukemia. As you will hear from David in the next talk, there is a number of effective agents approved in ALL, and also in AML we do have Gemtizumab ozogamicin as the first antibody-targeted therapy that has been approved, but there is potential for new approvals in the future. Gemtizumab is now an established agent, and this is from the ESMO 2020 guidelines on the role of antibodies and with respect to allogeneic hematopoietic stem cell transplant. And it's clear that Gemtizumab is now well established for use in at least patients with core binding factor leukemia, AML, where it is used both in induction and consolidation in addition to traditional induction and consolidation chemotherapy, and perhaps also in a group of patients with ELN1 and ELN2 classification AML. And we will go over some of the data that has led to this. Now, at my institution, we do use Gemtizumab universally for patients with core binding factor leukemia in our regimen of fludarabine, cytarabine, and G-CSF plus Gemtizumab. And as you know, we were the pioneers in establishing a non-chemotherapy-based therapy in APL, where in the high-risk patients, we also use Gemtizumab ozogamicin when the patient's white count at presentation is over 10. For other patients, as you all probably know, we tend to use clinical trials as our main strategy of therapy. So essentially, majority of patients are enrolled in clinical trials. And as you know, with the introduction of HMAs plus azacitidine, HMAs plus venetoclax, and particularly azacitidine, this strategy has a major role in older, unfit patients with AML. So for secondary AML, we have been using CPX-351 in appropriate patients. That has been shown to be useful, particularly in secondary AML and therapy AML patients, particularly older patients. But we are also incorporating a number of targeted agents into our frontline therapy, including FLT3 inhibitors, IDH inhibitors. And as I mentioned, we do use Gemtizumab ozogamicin, particularly for core binding factor leukemias, but also in some other intermediate risk patients. We will not talk a lot about measurable residual disease. We do assess that both by flow cytometry and now by next generation sequencing. And I think that's an important factor in the management of AML patients before and after transplant. So There are a number of markers on the surface of AML blasts. Some of them already have been targets for antibody-based drug development. Of course, CD33 was the first of these that has become a established target for antibody-based therapy. Of course, Gemtizumab osigomycin, as I mentioned already, was the first to be used in this setting in developing antibody-based therapy. But also there are other 33-based antibodies in development, such as AMG 330, which is a small molecule and has to be given by continuous infusion, similar to Blenhetoommab, but also a longer half-life, short infusion agent, AMG 673. Both of these are being evaluated in ongoing phase 1 studies. CD123 is also a marker that's believed to be present on many AML stem cells. And because of that, there's a number of strategies that are being developed targeting this marker, such as XmAb 14045 and Flutetusumab or MGD006, as well as antibody drug conjugates. Interesting new agents such as CD47 targeted magrolimab and CD70 targeted Casdozokitug are also coming on, and we will talk about these briefly later, as well as CD45, which has a role with the iodine 131 antibody, which has a potential role in allogeneic hematopoietic stem cell preparative conditioning. FLT3 is a surface membrane receptor and not related to FLT3 mutations. It also can be a target for antibody-based drug development. So as I mentioned, Gemtizumab was the first drug that developed in this setting. This is, as you see, is a humanized anti-CD33 monoclonal antibody, which is linked to a target, which is linked to a drug called calicheamycin. This is a very potent anti-DNA agent. Upon binding the CD33 on the surface of AML blasts, the antibody drug conjugate gets internalized, and then calicheamycin is released to cause AML blast apoptosis. It was initially approved, as you all know, in 2000 based on a phase 2 study that showed benefit in older AML patients in relapse with an overall response rate of about 30%, and then it was withdrawn. The initial study did report hepatotoxicity or sinusoidal obstructive syndrome, or VOD, but it's only about 5% of patients in that original study. Of course, confirmatory studies were designed. These were randomized frontline studies in patients with newly diagnosed AML. And in these studies, traditional chemotherapy, cytarabine plus anthracycline-based induction and consolidation was combined with small doses of Gemtizumab. I do want to emphasize the small doses because the original approval of Gemtizumab was for 9 milligram per meter squared on days 1 and 14. And in these randomized studies, much lower doses were added to the chemotherapy. So in the, for example, alpha study, the dose was 3 milligrams per meter squared on days 1, 4, and 7 in a fractionated strategy. In the MRC or NCRI study, only a small dose of 3 milligrams was added to the chemotherapy. The SWOG study that actually led to the withdrawal of the drug briefly from the market voluntarily by the sponsor was using a 6 milligrams per meter squared dose. And in that study, there was a higher incidence of induction mortality for the GO group. But I would like to mention that the mortality in that study reported induction mortality was about 5%, where in the treatment arm, and only about 1.5% in the control arm. And the 1.5% is obviously a remarkably good induction mortality reported for any study, and 5% is not that different from many other studies that have been reported. But of course, as I mentioned, the drug was voluntarily withdrawn from the market. And then the number of other randomized studies, both in Europe and US, matured. And the meta-analysis of these studies did show that although GO addition to induction and consolidation chemotherapy did not improve CR rate, but it did improve event-free survival and also in some studies overall survival, and particularly for favorable risk AML, which is core binding factor leukemias. You see on the right of the slide the degree of difference in terms of overall survival for this specific subtype of AML in core binding factor leukemia, which is a very strong indicator of the usefulness and efficacy of this agent in combination with chemotherapy for core binding factor leukemias. Of course, the meta-analysis did also show some statistically significant benefit for intermediate risk patients, but the degree of benefit was nowhere as close as to this group. And for adverse risk patients, there was really no benefit on adding Gemtizumab to initial induction and then consolidation chemotherapy. Of course, this has been what has been the concern with Gemtizumab, and that's the risk of sinusoidal obstruction syndrome, which is similar to VOD. As I mentioned in the original study, the reported risk was only about 5%, and this was mainly in the monotherapy setting using a higher doses. And then they did show that there are certain chemotherapy agents that increase the risk, for example, Thiotepa, and also the higher dose was considered to be a risk, and also transplant recipients. This retrospective review by the EBMT looked at the incidence of SOS or VOD in hematopoietic stem cell transplant recipients. Again, this was a retrospective review of about 150 patients. They did use various forms of prophylaxis. None of these are established, including heparin in 57 patients, Ursodiol in 8 patients, and defibrotide in 4 patients. They did report a cumulative incidence of 8% in 11 patients, including 3 deaths directly attributable to SOS-VOD. So they did report that if you use a lower dose of GO, the risk is acceptable in terms of SOS, while this is used in relation to hematopoietic stem cell transplant. Other studies have looked at risk factors for VOD and SOS. In general, of course, patients with underlying liver disease do have a higher risk. And as you all know, in this transplant audience, there are some transplant preparative regimens that are associated with higher risk, such as busulfan, particularly oral busulfan, and radiation as a part of conditioning regimen, and also the degree of alloreactivity. But a number of studies have now shown that there is a risk associated with both Gemtizumab and Inotuzumab in terms of increasing the risk of SOS-VOD in post-transplant. However, as I mentioned, the ALPHA study was one of the pivotal studies that was on the meta-analysis and did lead to the reinstatement of this drug by both the European and US approval agencies. This study was presented in ASH a couple of years ago from the ALPHA group. It hasn't, as far as I know, hasn't been published yet, but they looked at patients in the ALPHA study, which were 271 patients. And of these, 85 patients received allogeneic hematopoietic stem cell transplant at any time, either at CR1 or after relapse from a previous response. They did report that there was really no difference in terms of the risk of the survival probability in the GO versus control arm in the transplanted patients. You see that 32 patients on the GO arm had a transplant and 53 on the control arm. So Also, in terms of the risk of VOD, there was not a dramatic excess of VOD post-transplant in the GO-treated patients. Of the 3 patients that developed post-transplant VOD, 2 recovered and 1 died related to the VOD. So again, I think this shows that if we use the GO perhaps with lower doses and with more care, the risks of VOD are not dramatically higher than you would expect from patients who receive or undergo allogeneic hematopoietic stem cell. The study did meet its primary endpoint of improvement in event-free survival. This is a update of the publication. The original publication was published by Sylvie Gastain in Lancet Oncology, but this is an update from Hematologica that confirms the improvement in event-free survival for the GO arm in a highly statistically significant manner. However, as you see, despite the fact that GO arm did better than control arm in terms of overall survival, this was not statistically significant. GO is also combined with chemotherapy in the pediatric population in children and adolescent and young adults. This was a children oncology group study that had over 1,000 kids up to the age of 29 who were randomized to chemotherapy either alone with GO doses as shown here on the slide in induction 1 and intensification 2 cycles. And you can see that use of GO did improve the event-free survival, the gray and red bar, but not significantly the overall survival, but did result in a better event-free survival at 3 years, which was statistically significant. The benefit of GO was particularly apparent, depended on CD33 expression. This was a follow-up publication that looked at CD33 expression in 4 quartiles. The lowest quartile, or quartile 1, Q1, was the lowest expressing CD33 patients. In those patients, the addition of GO did not benefit patients in terms of relapse risk or event-free survival, but quartile 2 and 4 on the right of the slide, as you see, they did benefit from addition of GO to their standard induction and consolidation chemotherapy, both in terms of event-free survival and also the likelihood of relapse. So based on all of these data, as you all know, both the EMA and the FDA have now approved the use of Gemtizumab oligomycin in combination with chemotherapy, both for the adult and in the case of the FDA, also for the pediatric population. So I think the take home about GO is that it is an effective and available agent, and its risk of VOD can be lowered by using a lower dose of the drug. Moving on to other agents, especially that we are in a transplant audience, I'd like to mention this drug, Lomab-B, which is a CD45 humanized antibody linked to a iodine-131 radionucleotide that emits beta particles. CD45 is expressed on the majority of hematopoietic myeloid and lymphoid progenitors, as well as in lymphocytes in lymph nodes. So the use of this can provide radiation in a targeted fashion, and previous studies have shown higher doses of radiation in the transplant regimen does improve relapse risk and does benefit in terms of reduction of relapse. However, obviously higher doses of radiation, standard radiation, is associated with toxicity with organs, and the hope is by using a strategy like this, you minimize non-marrow delivered radiation. So this has led to this randomized phase 3 trial using Iomab-B, which is in patients over the age of 55 with active relapse and refractory AML, either with primary induction failure or with relapsed or refractory to salvage therapy, these patients have to have a donor available, 8 out of 8 matched donor, and there was a central randomization between the study arm, which uses Iomab-B. Patients receive this and then go on to receive an allogeneic hematopoietic stem cell transplant, or the control arm, which receives traditional salvage chemotherapy. Now, if the patients in the control arm did not achieve a CR, they could be crossed over to receive Iomab-B and then go on to transplant. As I mentioned, this was presented in a TCT meeting, and on the left of the slide, you see the format of the salvage therapies. About a third of the patients did receive targeted therapies, such as venetoclax-based strategies. And then on the right, you see the hematopoietic stem cell transplant rate after Iomab-B versus standard of care. 100% of the people who were randomized to Iomab-B went on, or that's 31 out of 31, went on to receive the transplant. On this slide, you see the days to ANC recovery. On the first column on the left, these are the patients, the 31 patients who receive Iomab-B. You see that the time to count recovery was actually quite reasonable, and days to hematopoietic transplant was, post-randomization, was a median of 30 days. In the middle column, those are the patients who did go to the control arm, receive chemotherapy or standard care therapy, and then were transplanted. Only 7 out of 38 underwent a transplant. After the transplant, count recovery was reasonable as expected, but days to transplant was about twice as long. On the last column on the right, these are the patients who were initially in the control arm and then did not receive a response and then underwent Iomab-B followed by transplant. And you can see 20 of these patients were transplanted, and the time to transplant was actually not dramatically long. Here is the mortality, initial 100-day non-relapse mortality for the transplant, which is 6% in the Iomab-B arm, 29% on the control arm that were transplanted, and then 10% for the control arm that then received or crossed over to Iomab-B and then were transplanted. And the delivery of the radiation is actually 15.5 gray for the initial Iomab-B arm of the study, and 14.4 gray for the crossed over patients. So this certainly shows that this strategy appears to be feasible, and the patients are able to undergo transplant even in the relapse and refractory setting. Now we are a bit running out of time, so I'm going to just focus on some of the new agents that may be coming. There's very little transplant-related data with these as yet, but I think this is important for a transplant audience to be aware of, because some of these drugs may be coming and be used at your centers with increasing frequency. So CD47 is a checkpoint on leukemic cells. It's a don't eat me signal that essentially prevents the macrophages from essentially phagocytosing the AML blasts. Blocking this signal using magrolimab, or an anti-CD47 antibody, was thought to be beneficial, and the early results of the study in combination with azacitidine were reported in EHA, both in the high-risk MDS as well as in AML patients, showing interesting responses, and we will hear more about this agent in the future. Also, this agent, which is a naked anti-CD70 antibody, is also being evaluated in combination with hypomethylating agents in AML, and we will see whether this drug significantly increases the responses with hypomethylating agents, and both in the MDS and AML settings. There are a number of bispecific antibodies in development. You will hear from Dr. Marks on Blenhetoommab in ALL. There is a hope of developing a similar agent in AML. There are a number of platforms that you see here. Some of these molecules are very small molecules, and so they have to be given by continuous intravenous infusion. AMG 330, for example, is a small BiTE molecule that has been evaluated in a phase 1 study and does have activity, but again, it is given by continuous intravenous infusion. But by adjusting the structure of the molecule, you can actually make the molecule larger and essentially increase its half-life so it can be administered by shorter infusions. And of course, that may be desirable for administration, although at least in our center, use of Blenhetoommab has not been hampered because of its continuous infusion dosing strategy. So however, with this drug, for example, you have a longer half-life, so it can be given by a shorter infusion. It is a bispecific antibody targeting CD3 on the T cells and CD33 on AML blasts, and this phase 1 study is ongoing. Flutetusumab is a different platform, is a DART molecule, still a small molecule. The target here is CD123 on the leukemic blasts and CD3 on the T cells. As you all know, this has been reported in a number of meetings, and this also is given by continuous intravenous infusion, and they reported respectable responses, particularly in primary refractory patients who had not responded to at least 2 cycles of induction chemotherapy, and the phase 2 of this study is ongoing. There is another drug that I don't have a slide for, which is the XmAb 14045, which is also a CD123-CD3 bispecific molecule, which is a short infusion agent and makes that very user-friendly. And this is also ongoing in initial phase 1 and soon phase 2 studies. So there are a number of antibody-based strategies in development in acute leukemias. I haven't talked much about measurable residual disease. My hope is that some of these BiTE or bispecific antibodies, perhaps also the antibody-drug conjugates, may actually be able to eradicate measurable residual disease, particularly prior to transplant. And obviously, there are data that suggest that MRD negative patients may benefit more from allogeneic stem cell transplant, although presence of MRD is by no means a contraindication against undergoing allogeneic stem cell transplant. And recent data by Chris Horrigan did show that the myeloablative strategy can overcome many of these MRD positive patients and benefit them in terms of long-term survival. So future studies will demonstrate how we can best incorporate these new antibodies, and hopefully these will all increase our armamentarium for treating patients with AML. Thank you very much, and we will discuss further at the end of the presentation.
Although we're a little bit short on time, Farhad, of all these novel antibodies, I mean, Go is established treatment, but of the novel antibodies, which one excites you the most? Which one do you think will make it to the bedside?
Well, David, I do have a little bit of conflict because I participate in many of these studies, and my biggest hope with all of these agents is more in the setting of measurable residual disease, because I think with all the new strategies that we are coming up in AML, both in the younger patients as well as in the older patients, we are getting better responses. And of course, the patients who have persistent MRD are the patients who would benefit from a different form of therapy. And I think an antibody-based therapy, particularly those that recruit the immune system, would be very exciting. I'm excited about magrolimab if the eventual data matures, because that's a very non-toxic agent, and you could eventually think of it as the rituximab for AML or myeloid diseases if it turns out to be that it truly improves the responses.
Great, thank you very much. So I think we might move on to my talk now, which is entitled Insights on the Integration of Novel Antibodies as Options for Transplant-Eligible Patients with ALL. And I'll just start with a slide about the European Working Group on ALL and EBMT position statement on transplant in ALL. And the first author is Sebastian Giebel, but I am a co-author of this paper. So in terms of transplanting in first remission, this is recommended for all patients who have features indicating a high risk of relapse, certainly for those patients with persistent MRD. And within the recommendation, sibling or matched unrelated donors are the preferred donors. The stem cell source can be peripheral blood or marrow. It's recommended for myeloablative conditioning. This contains TBI, but it recognises that some older patients and those with comorbidities, reduced intensity transplant is certainly permitted. This slide shows the three main target antigens in ALL, CD19, CD22 and CD20, and it shows that they are acquired at different times during B-cell maturation. And just to review the regulatory status of the two main targeted therapies, Inotuzumab and Blenhetoommab. So they're both approved by the two main regulatory bodies for relapsed refractory ALL, and Blenhetoommab is certainly approved in children as well. It also has an additional indication, which is in MRD persistent disease greater than 0.1%, either in first or second remission. This shows the molecular structure of Inotuzumab. So there's a humanized anti-CD22 antibody, a short linker, and then the cytotoxic payload is calicheamycin. And this slide is a schema of the mechanism of action. So the antibody drug conjugate binds to CD22 on the cell surface, and the result of this is internalization of the molecule and then subsequent release of calicheamycin. This binds to double-strand DNA, causing double-strand breaks and subsequent apoptosis. This slide shows the schema of the pivotal INNOVATE study, which was a comparison of Inotuzumab versus standard of care chemotherapy in relapsed refractory CD22 positive ALL. It was a 326 patient study, a 1-to-1 randomization. Patients could be Philadelphia negative or Philadelphia positive and could be first or second salvage. They were stratified by duration of first remission, with 12 months being the dividing line, by their salvage status, and also by age, with 55 years being the dividing line. Inotuzumab was given at standard doses of 1.8 milligrams per meter squared in three divided doses, 0.8, 0.5 and 0.5. And this was compared with investigated choice of chemotherapy, and it was fairly prescribed. It was FLAG, it was high-dose Ara-C, or cytarabine and mitoxantrone. And it's worth noting that there were two primary endpoints: response, which was complete remission, I'll show you shortly, and overall survival. So this looks at response or complete remission with or without hematologic recovery by the stratification factors. And I think the main thing to draw your attention to are the complete remission results in first and second salvage. In first salvage relapsed refractory ALL, there was an 87% complete remission rate, really quite astoundingly good. It's not bad in salvage too, it's 2/3 of patients, 66.7%, but it's certainly less than in first salvage, and this points to when we should use the drug. This looks at duration of remission in responders. The top blue curve is the Inotuzumab curve, and it's significantly better than the standard of care curve with the brown colour, with a hazard ratio of 0.55 and a significant p-value. And this looks at progression-free survival, and there's really daylight between the curves. It's 5 months versus 1.8 months, and the curves stay apart really the whole of the time of follow-up. The overall survival curve needs a bit more comment. So this is taken from the Conjugates long-term follow-up paper, which was last year in Cancer, and it's a great strength of the Inotuzumab data that we now have 3-year survival figures, and it's 20.3% for Inotuzumab and 6.5% for standard of care, which very much agrees with historic studies from the UK and from France. So I think you'll note that the curves stay together for about 14 months and then they diverge, and they clearly are different. So you might say 20%, it's not that great. It isn't as much as one would wish, but it definitely is better than what we've achieved historically, and this resulted in FDA approval. So in terms of longer term outcomes, this slide shows the importance of proceeding to a transplant. And you'll see on the top sort of pinkish curve compared to the bottom purpley curve, the patients who had a follow-up transplant did significantly better. There's a hazard ratio of 0.55 and a very low p-value. Other things that were found to be important were the best MRD status. So what about MRD assessment? Of the 121 of 164 patients who achieved a remission, they had MRD assessment, and 76 were MRD negative and 45 MRD positive. And essentially the patients who achieved MRD negativity had significantly better overall survival and progression-free survival, with hazard ratios of 0.51 and 0.42 respectively. And this is graphically shown, and I think perhaps it's best to focus on the curves on the right, the median overall survival. It's a complicated survival curve to look at, but essentially, MRD negativity improved outcomes whether the patients were transplanted or not. What about safety data? Well, it's a complicated slide, and I think the one thing I'd like to focus on is neutropenic sepsis. So that was either called neutropenic sepsis or febrile neutropenia. If you look at the far left, any grade, and add those two together, they're in bold, it's about 13%. And if we that's with Inotuzumab. If we compare it with standard of care, again the any grade, that totals up to about 22%, or nearly twice as much. So that's important because obviously we don't want patients to have neutropenic sepsis, but it means those patients could be at home, and it also means that without neutropenic sepsis, the Inotuzumab patients were more likely to arrive at transplant in good shape. What about antibody drug conjugates and VOD risk? So this comes from the Contagion Lancet Hematology paper. He's the first author, I'm the last author of this paper. And essentially in the group of patients who got to transplant, there's a 22% incidence of VOD or SOS in the Inotuzumab arm versus 3% in the standard of care arm, so clearly significantly higher. And it was able to define the factors associated with this, so age above 65, conditioning with 2 alkylating agents, and also an elevated bilirubin pre-transplant. And this slide now is really the summary slide of the paper that we wrote about transplant after Inotuzumab, published in BBMT just last year. I'm the first author of this paper. So what we did is we combined the 73 patients who were in the Innovate study and combined them with some additional patients from a phase 2 study conducted at MD Anderson and Dana-Farber, who also proceeded to transplant, giving us a total of 101 patients. So first focus on the bottom curve. This is the outcome of all 101 patients, and they had a reasonable survival of 41%. If we just look at the patients who'd had no prior transplant, a slightly lower number, that's the middle curve, the outcome was a bit better, it was 45%. But finally, if we look at the patients who were having their first transplant and went directly to transplant after achieving remission, that's the top curve, and now their survival is 51%. So it's starting to get quite reasonable. Just a little bit of data from the TCT meeting earlier this year. So this was a look in very small numbers of patients, a phase 1 study at seeing if post-allograft maintenance therapy with low-dose inotuzumab, could it be safe and could it reduce relapse? And you'll see that they looked at 4 dose levels, all quite small doses, and gave them in 28-day cycles. I don't think we can say much about these numbers of patients except that there were no patients experienced veno-occlusive disease, and I think it's of some encouragement that the patients are alive and in complete remission at 1 year post-transplant. So just some of my thoughts about the inotuzumab experience and the implications for transplant. So if a patient has abnormal liver function tests or a significant past history of liver disease, I don't use inotuzumab first up, I'd give them Blenhetoommab. I've never had to give a patient more than 2 courses of inotuzumab. That gives you 8 to 9 weeks to do the transplant. In the era of the universal donor, I think that's normally sufficient time. You don't really gain much from the 3rd dose anyway. Keep your eye on the liver function tests, stop or interrupt the dosing or dose reduce if there are LFT abnormalities. I avoid all other hepatotoxins. They muddy the waters but also potentially affect outcome, perhaps particularly azoles. Have a high index of suspicion of VOD. It's not always an easy diagnosis. If there are persistent features of VOD, even if the ultrasound's normal, consider a biopsy if it's safe to proceed. And be careful with conditioning, dual alkylators and probably busulfan. So I'll now move on to Blenhetoommab, and this slide summarizes its mode of action. So it's a BiTE antibody, so 2 arms. One arm attaches to CD19 positive tumour cells, the vast majority of ALL cells, and the other arm to CD3 positive T cells. And so it brings the T cell into close apposition with the tumour cells, and this causes redirected cell lysis that kills the leukemic cells. And this is the schema of the pivotal phase 3 study tower, talking about randomization and dosing. So this was an even bigger study, 400 patients. It was a 2-to-1 randomization, 2/3 got the experimental arm. Patients were recruited at various stages of disease, include quite refractory disease. And the Blenhetoommab arm received Blenhetoommab initially at 9 micrograms per day for 7 days, then escalating to 28 micrograms per day. This was compared with a somewhat broader range of standard of care chemotherapy than the Innovate study. It was FLAG plus or minus anthracycline, high-dose Ara-C, high-dose methotrexate, or clofarabine-based regimens. First of all, to look at efficacy, and I think it's best to just focus on the overall response bars on the left. So this is CR with or without hematologic recovery. And for Blenhetoommab, it's 44%. For standard of care, 25%. That's 19 percentage points difference, and that's highly significant. What about survival? Well, I think the first thing to look here in these curves is that this is a positive study. Blenhetoommab's median overall survival was 7.7 months, and it was 4 months with standard of care. The hazard ratio is 0.7, and that is significant. I think we should also point out this is quite short-term follow-up. When the New England Journal paper was published, there's less than 12 months follow-up in the survivors. I think we should also comment on the shape of the curves. If you look at the curves at about 4 to 5 months, they're really quite widely divergent until about 9 to 10 months. And then the standard of care curve comes up and meets the experimental curve. So we're not entirely certain of the reason for this. It's possible that some patients on the standard of care arm access Blenhetoommab or possibly other agents such as Inotuzumab. The other thing is that we don't really get a feel for long-term survival, but I'm pleased to say that Amgen are collecting long-term data from this trial. It's been somewhat interrupted by COVID. And this looks at the patients who had on-study hematopoietic transplant. And the best outcomes with Blenhetoommab were observed in patients who achieved minimal residual disease remission, whether or not they went on to a subsequent allogeneic transplant. So also briefly, we should talk about adverse events. There's a high incidence of adverse events in both arms. If we look down to particular grade 3 and above adverse events of interest, there's a bit of noise with neutropenia and infection, but you'll see it's higher with standard of care than it is with Blenhetoommab. Neurologic events occurred in 9%. That, perhaps somewhat surprisingly, was not significantly more than that seen with standard of care. Cytokine release syndrome that was noted by the investigator as an issue occurred in 5%, and it did not occur in the chemotherapy arm. This slide looks at neurologic toxicity in a little bit more detail. So it's a little bit more in the Blenhetoommab arm, but not statistically significantly so. There was one grade 5 event in the Blenhetoommab arm. This was very sadly a suicide. But if we look at all the other neuropsychiatric events, some of them were secondary to other phenomena such as cytokine release syndrome or HLH. Now moving on to the other main use of Blenhetoommab, this is its use in MRD positive or persistent ALL, and this is the BLAST study. 116 patients, they had to have MRD greater than or equal to 0.1% after 3 intensive courses of therapy. And they could be CR1 or CR2. The dose of Blenhetoommab a bit different. It's 15 micrograms per meter squared per day. And the primary endpoint was a complete MRD response after 1 cycle of Blenhetoommab. So just the main findings. Amongst the adults with MRD positive ALL, 78% achieved a complete MRD response with Blenhetoommab, and unsurprisingly, those that did had a significantly improved overall survival. And it's worth noting that 2/3 of these patients underwent transplant in continuous remission after Blenhetoommab. And the survival of the patients is shown on the next slide, and the full line is the patients who got a transplant, and the dotted line those who did not. And there's obviously no difference between those curves. There wasn't a benefit demonstrated for those who had a transplant. So what about looking at the patients in the TAO study who had Blenhetoommab, then had a transplant in first salvage? So there were 32 of those patients, and 20 of them, so about 2/3, underwent transplant in a Blenhetoommab-induced CR. The follow-up's quite short, but to look at 1 year overall survival for all the patients, it was 55%, and for the patients who achieved it in remission, it was really a very encouraging 70%. I think it's not surprising that those with short first remissions, extramedullary disease and high peripheral blast, they didn't do as well. So just some thoughts about the BiTE antibody experience in ALL and perhaps the implications for transplanters. So it's pretty clear that Blenhetoommab is better than standard of care in relapsed refractory ALL, and it also has an additional indication, MRD persistent disease. As Farhad alluded to, its method of administration does require a degree of logistic planning, but I think we're all getting used to that. It's becoming more standard, although staff do need some training in it. And I didn't present the data, it's less effective in relapse when the blast count exceeds 50%. It has distinct toxicities, but I would say that these are largely manageable. Again, data I did not present. There are 2 US studies showing that there's a low but perhaps significant incidence of CD19 negative relapse, which can have implications for subsequent therapies. And finally, I just might leave you with some real world data. It has some limitations, but I thought it should be shared. So this was also data presented at TCT this year, and the top 2 curves are 85 patients who received Blenhetoommab, and the bottom 2, 21 patients who received inotuzumab outside of clinical trials, who they achieved remission and went on to transplant. In no way can you compare Blenhetoommab and inotuzumab. That's not the point of this. I think it's of some encouragement that although the follow-up is short in both cases, that there is some evidence of plateaus, and those plateaus are at quite respectable survivals. So I think we're in good shape, and we might move on to the third talk, which will be given by my colleague Professor Stellis. Matthias, would you like to give your talk?
Yeah, thank you very much, David, and thank you very much for the organizers to giving me the opportunity to share some practical ideas on the use of antibodies in AML and ALL. Now I would like to show you 4 cases, 4 patients, 1 with an AML and 3 patients with an ALL who received different treatments prior transplant, and the last one, which never received a transplant, but however this last case is something of a surprise maybe for all of you in the audience. So I would like to start with the first case. This is a 43-year-old lady. She was diagnosed with a high-risk pro-BALL in May 2018. She received the standard induction therapy according to the GMALL study group protocol. After the first induction therapy, she had persisting disease. Then she went on to the second induction therapy, and again she had a persisting disease with 20 to 30% bone marrow blast. The leukemic blast expressed CD19, CD20, CD22. So we had different options for targeting this disease. Of note, this patient had very good clonal markers for further follow-up for MRD measurement by PCR. So at that stage, we thought about different options, what to do. So one option was to go for standard intensive chemotherapy. And as you already have seen from the data David presented to us, standard chemotherapy is clearly inferior compared to the novel available treatments with antibodies. Then another option would be a direct allogenic transplant. I would will show you some data on that, and obviously both novel antibody-based treatment strategies. Of note, CAR T cells are nowadays one option, but mainly in clinical trials. And in our case, we did not have the opportunity to offer our patient such treatment. So in our patient was more than 6 weeks in hospital. She had some problems with infectious complication. She was or is still a mother of young children, and she wanted to go home. So based on this and with no contraindication for either drugs, we decided that maybe the easiest would be to choose a strategy which allows her to go home and receive the treatment on an outpatient basis. So then she received Flutetusumab the first cycle in July 2018. After that, she went into hematological remission, but stayed positive with minimal residual disease on a relevant level. After the second cycle, we have had nearly the same findings. And now at that point, I would like to ask my both colleagues, or probably David, you already mentioned that a third cycle should be avoided. Would you choose a third cycle in that setting, or maybe switch to another treatment, or would you go directly to transplant?
So this is an unusual patient. I think that the data are that a third cycle, there's really no shift between the first and second course, and I think a third course is unlikely to achieve MRD negativity, and it may add toxicity. So I'd move to a different strategy, and if it was available to you, I certainly would have considered Blenhetoommab.
Yes, we thought about Blenhetoommab, but one argument against another antibody-based treatment option was that we may have a risk for refractory disease if the patient did not respond to that second approach. And maybe one slide to the question, one or two more than 2 cycles of Flutetusumab. So we have the potential of increasing MRD negativity according to the INNOVATE trial of around 10%. However, as already said by David, we had a quite stable finding after the second cycle. So it's quite unlikely that we will improve the outcome according to MRD level. Another issue maybe to mention is that VOD risk increases with the number of cycles. So as you can see on the right, patient receiving 3 or more cycles have a higher risk for VOD. So that's another argument not going for more than 2 cycles. Direct transplant in the MRD negative settings is obviously the best option, as shown on the left. However, patients with MRD positive findings prior transplant have a inferior outcome to those with a negative outcome. So in our case, we were quite afraid of a second refractory disease, and we decided to go directly for an allogenic approach with a quite intense conditioning regimen. This is based on a small publication from the colleague from Düsseldorf. It's a combination of total body irradiation with a Flamza regimen, usually used in the setting of patients with refractory or high-risk acute leukemia. Our patient had a well-matched donor, and she received defibrotide as a prophylactic treatment within a clinical trial. After transplant, so directly after transplant and the follow-up, during the follow-up, we had no evidence of VOD. She had a first hematological CR, MRD negative, positive still after transplant, with decreasing measurable disease until February 2018. With that, we decided to give her donor lymphocyte infusion, and after the first donor lymphocyte infusion, she had no detectable minimal residual disease. 2 additional cycles followed the first one, and she remained in remission with some side effects, especially moderate chronic GVHD of her eyes. In October 2019, she had a molecular relapse, and at that stage, actually, we decided to go for Blenhetoommab. However, even after 3 cycles of Blenhetoommab, she stayed positive with a minimal residual disease on nearly the same level. And at that stage, we thought it makes no sense to give a 4th cycle. And now she had received a 5th DLI in this month, and we're waiting for the follow-up. And I would like to hear your opinion about that case, especially what to do in the future when she's still MRD positive again, or if she relapse. Would you go for an second allo transplant at that stage, or wait for the overt relapse?
Can I make a comment in terms of after your Inotuzumab and before proceeding to transplant? I think one thought is if you use Blina at that period, we have a 78% MRD conversion using Blenhetoommab in the pivotal study. The other benefit of using Blina is to increase the time from your last Inotuzumab to the time of transplant. And I know that the data is not solid, but that could reduce the risk of VOD. So there is a sort of a double advantage from using Blina after your Inotuzumab before proceeding to transplant. And one other comment I actually also wanted to make is that, of course, Inotuzumab was approved in the relapse setting as monotherapy, but clearly there are now studies that suggest that if you combine it with lower doses of chemotherapy, you may actually improve your responses even further and increase your MRD negative rate. So that's of course, in the future, there may be, one may consider the combination strategy with Inotuzumab rather than just monotherapy with Inotuzumab in the relapse setting.
Okay, thank you very much for this important comments. I actually do think the same. The combination of Inotuzumab probably as a kind of a debulking therapy in patients with a relapsed disease, and then follow up with Blenhetoommab to improve response and improve MRD response prior to transplant is a quite interesting approach. However, it's not really available for patients with low MRD levels according to the label, and I would love to see a prospective trial on that.
Yeah, no, I think Farhad very possibly has a valid point, but we wouldn't be able to use it with mini hyper CVD as they have in MD Anderson. Although we know that's a safe thing to do, we're just not able to do it.
Okay, thank you very much. And then I would like to move to the second case, maybe more classical, but with one controversial point. So this is a quite young patient, 20 years of age, at his first diagnosis. So he was diagnosed in November 2011, received a standard intensive chemotherapy according to our national study protocol. And then more than 2 years after remission, he relapsed in August 2014. He had 70% bone marrow blast. Blast expressed again both targetable antigens, and he had again quite good measurable disease by PCR. So what to do in this patient? So first I would like to discuss again the issue of disease burden. As already mentioned in the previous talk, patient with high disease burden had no difference according to response compared to patient with lower disease burden. So both had quite good results in the INNOVATE trial. Bearing in mind that Blenhetoommab had not the same observation, probably today Inotuzumab would be the best choice in case of no contraindication. The other issue is that there are some data out that, especially in patients with late relapse, conventional chemotherapy also may result in a quite good response and survival after relapse treatment. However, the INNOVATE trial was it was possible to divert the subgroups by remission duration, and as you can see here, the upper curve are those patients with long remission duration, more than 12 months, who received an Inotuzumab as a relapse treatment. These had quite better survival compared to those with standard chemotherapy, and the advantage of the overall survival is clearly related to the numbers of patients receiving an allotransplant as a subsequent treatment. So in our patient, this was actually the first patient who was treated with Inotuzumab at our center. We were able to achieve a second CR after the first cycle. This patient was 3 days in hospital because it was the first patient and we were not aware of the easy application of that drug. The second cycle was applied in the outpatient setting, and again further on the patient stayed in complete remission. He had an available unrelated male donor, so at that stage obviously the transplant was planned, and I just want to remind you that patient was proceeding directly to transplant had the best outcome directly transplant after Inotuzumab treatment, and in our case we had a quite good long-term follow-up. He's now 6 years after transplant, alive and well, in complete remission, and still again working and having his normal life. So that's quite encouraging results in that patient. And in addition to that, the patient had no signs of VOD. So any one of my both colleagues would use conventional therapy as a relapse treatment in such a patient?
I mean, I just think Inotuzumab is extremely effective in this setting. With at least 3/4 of patients will go into remission, and 3/4 of those will be MRD negative. And really, I think you've made all the right calls, and this patient is very likely cured.
Of course, we do have, as you heard from David, the mini CVD plus and that's highly effective. But of course, in this patient, the outcome speaks for itself.
Okay. Yeah, maybe one issue with regard to the combination therapy. According to the data from the INNOVATE trial, we have a quite high remission rates with the monotherapy. And I'm not quite sure if we need a combination with conventional chemotherapy when we have remission rates with high MRD negativity in most of the patients, especially when we have patients where we are able to plan a transplant within a couple of weeks or 1 or 2 months. Probably in these patients, a monotherapy would be sufficient, and maybe in the future the addition of another antibody-based treatment therapy when there is still MRD positivity prior transplant. Okay, with that I would like to change the disease. So now we had seen 2 patients with ALL. The third patient is a 63-year-old patient with an acute myeloid leukemia, which received treatment with GO, as you probably can imagine. And so this patient was first diagnosed in January 2019. According to the risk profile, he had an intermediate risk, or ELN2. At the first diagnosis, he had 90% bone marrow blast, a normal karyotype, and a variant CBP alpha mutation. So after the first induction therapy, 7+3 + GO in January, he achieved a complete remission with no detectable mutation as described previously. And after the second patient induction therapy with 7+3 + GO, The patient was still in complete remission, had some severe infection problems after the first induction therapy. According to the donor search, we were able to identify one unrelated male donor. This was a 9 out of 10 HLA-matched donor with one antigen mismatch for HLA-A, permissive DP mismatch, and this CMV negative status for both donor and recipient. So would you go for an allotransplant in this setting as a consolidation therapy?
This is an older patient. Of course, I would take into account all of his comorbid conditions and status. Of course, he has intermediate risk disease, and he has only monoallelic CBP alpha mutation. So unfortunately, that's not producing him in favorable long-term outcome. If he was biallelic, certainly I would not. In my practice, I probably discuss the risks and benefits with the patient. Unfortunately, there is a good likelihood of him relapsing. So if the donor is available and the patient is in good condition and he's understanding the risks, I probably would proceed.
Okay, thank you. So you already have shown the recommendation from the ELN. So allogenic transplant in that setting is an option. On the other hand, conventional consolidation therapy is another option. And we have no randomized trial on the value of allotransplant in the setting of patient in first complete remission with AML with intermediate risk, with an intermediate risk. We have one quite important study, I would say, from our German study group. In that study, we performed a prospective matched pair analysis where we compared patients receiving conventional post-remission therapy to allotransplant in first complete remission. And as you can see on the left, the incidence of relapse after first CR raises up to 70% for those patients not receiving an allotransplant in first remission, compared to around 20 to 30% for those transplanted in first CR. When you see on the look on the right, you have here the numbers for the overall survival, and for the whole cohort, mainly patients with intermediate risk AML and some with high risk AML, so a matched cohort according to AML risk factors, age, and some other factors. This study was able to show a benefit for the allotransplanted patient in first CR. However, the drawback of this approach is clearly the incidence of non-relapse mortality, so the toxicity of the transplant. In our case, we decided that a mismatched donor might be the potential of higher GVHD incidences. The patient had severe infection complication after the second cycle of induction therapy, so he received conventional consolidation therapy. After the first consolidation therapy, he stayed in a remission, and after the second, sadly, he relapsed with an quite proliferative disease with more than 50% bone marrow blast, no new mutation detected. And after that finding, we decided to give the patient a standard salvage therapy with FLAG-IDA, and after that treatment, a second complete remission could be observed. You are maybe aware of the upcoming data during the last years that were able to show some ideas that a conventional relapse treatment is not really necessary, and that maybe a direct transplant for patients with relapse disease, if possible within a couple of weeks, can result in nearly the same survival curves like those patients receiving a salvage therapy and then transplanted in a subsequent remission or with persisting disease. What is your approach in the US? Would you go for a direct transplant in patients with a relapsed disease?
I believe there is data that the percentage of blasts in a situation of direct transplant is very predictive of outcome. So someone who has 50% blasts, I certainly would want to reduce the disease burden. And the salvage regimen that you mentioned, we and our center at least are now adding venetoclax, and with that regimen, we are having very remarkably high responses. Now, you achieved it just with FLAG-IDA alone, but we do get remarkably high responses. Now, it is a very, very myelosuppressive strategy, and it has a very high risk of producing sepsis. So if I were ever to do it, I would do it very carefully. But I believe, especially with a 50% bone marrow blast, I would definitely like to have some degree of reduction in disease burden before proceeding to a transplant.
Okay. There's one ongoing trial in Germany which randomized patients for direct transplant versus chemotherapy, salvage therapy. I hope the data will be out in the next 2 years, and we are looking forward to give you some new ideas on the value of intensive salvage treatment in those cases. So given these data, we choose tyrosine conditioning regimen. The patient received this transplant in August last year. He had no signs of VOD. After transplant, he developed a quite relevant GVHD of the gut and skin, which required immune suppressive therapy for 5 months. And sadly, after being able to taper the immunosuppressive treatment, the patient relapsed in May this year, again with a quite high disease burden. He did not respond to azacitidine. We thought about venetoclax, however, due to disease progression, we had to start with hydroxyurea, because venetoclax is only possible when we have the permission from the healthcare provider to use this. And at that stage, we started off thinking about what to do at this diagnosis of relapse. And one option obviously is to go for a second transplant. I know these data, or the idea of a second transplant, is quite controversial. If you look at the data from the German register published in 2013, patient receiving a second transplant with relapsed AML had a survival of around 20%. Those patients with a longer remission duration, so longer than 6 months after first transplant, had a better survival. All other factors like disease burden, active or non-active disease, were not significant in that analysis. More recent study published last year from the EBMT showed that a patient might have a better survival nowadays of around 30 to 40% survival when receiving an second allotransplant. And as you can probably imagine, risk factors like disease status, cytogenetics, and so on are quite important when you're asking or thinking about a second allotransplant. At MD Anderson, second allotransplant an option?
Oh yes, definitely. Absolutely. We have actually considered third transplant in rare patients.
Okay, well, we did the same, and there's one EBMT analysis out summarizing the data from the third for patient receiving a third allotransplant. However, as you can imagine, a mixture of patient from the register was only able to show survival rates of around 10%. So I think it's a possible option for patients, for some very selected patients. So with that, I would like to summarize the first cases. As shown from the previous talks and from both cases just shown, in ALL, both antibody-based treatments are superior to standard chemotherapy, and we have now great opportunities to treat our patients with relapse or refractory disease. In AML, Gemtizumab has obviously improved response rates and survival rates for patients in the combination with standard chemotherapy. The fear for side effects, especially VOD, might be of a minor problems after allotransplant when using novel conditioning approaches. With that, I would like to come to the last and probably a little bit controversial case. This is a 73 years old lady with acute lymphoblastic leukemia diagnosed in March 2017. She received age-adapted intensive chemotherapy for 1 year and then sadly relapsed in June 2018 after 1 year remission duration. She had 80% bone marrow blast. Again, all blast expressed targetable antigens by both antibodies just discussed. And the other findings were not clinically important. In that case, the normal karyotype and again, 2 clonal markers for MRD measurement. When we look at the INNOVATE data, we have some evidence that the response rates are quite good even in elderly patients. However, the age cut point in the published analysis is 55 years of age, and the overall survival probably most likely related to the fact that most of the patients did not receive the subsequent allotransplant, was quite similar to those with receiving standard chemotherapy. In our case, we decided to go for Flutetusumab, especially due to the fact that she had a quite high disease burden and she didn't like the idea of being in hospital again. So she received 1 cycle of Flutetusumab, and just after the first cycle, she had a second complete remission, which was MRD negative. And during the follow-up, she received 5 additional cycles until October 2018, and no signs of VOD. Moderate pancytopenia as chemotherapy-related toxicity, continuous complete remission, MRD negative during the whole observation period. During the treatment, she was 2 days in hospital at the start of treatment and then received the whole treatment on an outpatient basis. And we saw 1 to 2 times per week for treatment control. 8 months after remission, second remission, she relapsed again with 10 to 20% bone marrow blasts, and at that time point we had a study open for CAR T-cell treatment, which allowed also inclusion of elderly patients. She agreed to participate in that trial, and we performed the leukapheresis for the CAR T-cell treatment. During the follow-up after the leukapheresis, she had a disease progression with a ZNS manifestation. This was a contraindication for that trial, and she was not able to conclude in the CAR T-cell trial. Then at that stage, after starting intrathecal therapy, we thought maybe Flutetusumab would be one option to get her in remission again. However, after 1 cycle, she had a stable disease, and most likely, according to the intrathecal therapy, she had no active ZNS manifestation. At that time point, we were able to get the CAR T-cell product on a compassionate use basis, and she received her CAR T-cell application after standard lymphodepletion therapy in May 2019. No relevant side effects. Third complete remission, MRD negative again, and as you can see in the figures, we were able to follow up the CAR T-cell expansion for up to 8 weeks. With the peaks at around day 10 to day 20 as shown in the upper bar. 6 months later, in December 2019, she relapsed again. Now again with 2 to 20% bone marrow blast and again ZNS manifestation. Then we reintroduced intrathecal therapy with MTX, RC, and dexamethasone. And after clearance of the leukemic blast in the liquor, we started with Blenhetoommab in January 2020. She had a transient neurotoxicity, which was easy to manage, hospitalization for 10 days, And after that, after the first cycle, she went in the fourth remission, being MRD negative again and no active ZNS manifestation. Briefly, the data on the Blenhetoommab results in elderly patient published 4 years ago. So as you can see, according to the survival, the elderly patient aged 65 and older had a similar outcome compared to the younger patient, and remission rates in the elderly patient were reported at around 50%. So quite an active treatment even in elderly patient. In our patient, we continued with 3 additional cycles of Blenhetoommab until April this year, no relevant side effects. And again, in June, she had her 4th relapse with mainly ZNS manifestation, so leukemic blasts in the liquor, some blasts, but only no numbers in the bone marrow. And as a last treatment, we decided to give her an additional cycle of Blenhetoommab after blast clearance of the liquor. So with that, I think at least with that case and in combination with the available data, Flutetusumab and also Blenhetoommab are quite effective in patients, even if they cannot go directly to transplant or have no option for transplant. In our case, we were able to control disease for a couple of years with quite good quality of life of the patient, so she was able to see her family during the whole treatment. And interestingly, in our case, Flutetusumab was used as a bridge prior CAR T-cell therapy, so she had no disease progression after Flutetusumab, and despite the fact that we targeted B cells with a CAR T-cell, were effective in this patient. So with that, I would like to close my presentation, and I think we have a bright future with all the available therapies now for patients with ALL and AML, particularly those antibody-based therapies, and we can now probably discuss the last case.
Well, thank you very much, Matthias. I don't really have any questions, but I think it is a good example about. I do have a few patients where they've had an allograft and they've relapsed, and I've given the patient a good remission with Inotuzumab, say, and then they relapse, and then they respond to Blenhetoommab, and they get a good additional time, and almost all of it is at home. So even when you can't cure the patient, these drugs can significantly prolong life with good quality. Farhad, do you have any comments about sequencing of therapy or the use of these agents palliatively?
Yeah, as we have done throughout history of oncology, we approve drugs in the relapse setting, and my comment is that we have to start designing strategies that we use these in the front line in combination with each other, and also with cytotoxic chemotherapy. As you know, we are doing that in our center. But as you said, yes, I have had patients over age of 80, 85 that I have managed with these antibodies, of course, in the absence of transplant, for several years. These agents have truly revolutionized treatment of ALL. As I mentioned, we hope to have similar antibody-based strategies in AML because with the targeted therapies we are doing much better, but still we need a lot of improvement in the treatment of AML patients.
Thank you very much. I think we'll close there, and I'd like to thank my 2 co-speakers for excellent talks and really good discussion. So thank you very much for joining us, and have a good rest of the day.
This activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.